Good evening, everybody. Today, I am going to discuss about the radiology of cancer cervix, which will help you understand the surgical evaluation as well as the target delineation for the radiation oncologists. So, if you see the gross staging of the CS cervix, if it is a 2A, it is limited to the cervix and upper two-third of vagina. So, if you 2A, it is less than 4 centimeter surgery, and till less than 4 centimeter, stage 1 to less than 4 centimeter surgery. More than 4 centimeter to the onwards, it is the radiation is the standard. Radiation chemotherapy is the standard. So, if there is a lymph node involvement, it directly takes 3C, and bladder bowel involvement 4A, lower third vaginal involvement 3A, and parametrial involvement medial is 2B, and ureter, hydronephrosis, and lateral wall involvement till it is stage 3B. If you see the gross anatomy, this is the myometrium, this is the serosa, this is the endometrium, this is the uterine cavity, this is the internal os between the cervix and uterus is the internal os, cervix and vagina is the external os. And if you see same thing here, extrapolating in the MRI, this is the cervix, this is the endometrium, this is the endocervical canal, this is the cervical stroma, this is the vaginal wall. So most of the times we send the MRI to the radiologist for the discussion about the surgery versus radiation, target delineation, the radiation oncology. So there are two things. We have to take large FOP. Mostly T2 weighted images required. No contrast usually required. You have to take from renal hilum to pubis to understand the parotid pelvic lymph nodes, hydronephrosis, peritoneal spread, and bone. But small FOP required to sagittal, coronal, and axial to understand the tumor, vaginal involvement, vaginal cervix involvement, and endocervical extension, vaginal involvement, and parametrial invasion. Diffusion weighted image is required to understand the exact disease and hyperintensity area as well as the response assessment. Mostly fasting 4 to 6 hour empty bladder if you are using contrast. Antiperistaltic agents like buscopan or glucagon can be given. Optional vaginal gel to assess upper vaginal involvement. Note that contrast enhanced images are not required for cervical cancer staging. Scheduling the examination according to the menstrual cycle is not required. When you are getting the MRI report, you ask a radiologist to report all these things: tumor size, parametrial invasion, vaginal invasion, lower third, upper two third, pelvic sidewall invasion, sacrouterine ligament invasion, uterine involvement and hydronephrosis, bladder and rectum invasion, and lymph node involvement. If you want to go through the MRI protocols, JKIST working group for publication, you can go ahead and see what they are doing. Suppose you are getting a bowel movement artifact, you can use glucagon and buscopan to decrease the age without glucagon and buscopan, and with glucagon or buscopan, you can see the bowel artifacts are removed. Usually, people have a false belief that T2 MRI, 3 Tesla MRI, 5 Tesla MRI looks good for the cervix delineation, but lower Tesla MRIs are better. If you see, this is the 1.5 Tesla. You can see the same thing in 0.2 Tesla, how the tumor looks better in the lower field MRIs. So how it looks like, mostly the T2 hyperintense area in the cervix, mostly it looks like hyperintense area. It may be exophytic, it may be infiltrating the wall and the cervix, and it may be endocervical, starting from the endocervical and the vagina to cervix to come up, occluding the lumen. You can get see this is the collection. You have to measure the length in various directions, and you have to find out in exophytic, endophytic, infiltrative lesions, and you have to measure. Very important thing to understand the parametrial involvement. This is called a hyporing. So this is the tumor, and this is called a hyporing. If this hyporing is breached, then it is the parametrial invasion. You can see this area, there is no parametrial invasion, hyporing is persisting. But here in the right side, you can see there is a parametrial invasion is there. You can see sometimes it looks like a infiltration, but really it is an expansion. So you have to see in all coronal sagittal sections, you can see the hypouring in all directions. Sometimes we have to understand whether pelvic sidewall involvement or not. So if you to you have to see the obturator internus, piriformis, iliac vessels, and levatrinae muscles. If it is within the involvement is still the less than 3 mm, till you have to see the wall to distance it is less than 3 mm, we tell as a pelvic sidewall involvement. Another thing is the sagittal section. You have to see the uterosacral ligament. It is connected from the posterior border of uterus to the pelvic sacrum. If that is involvement, you have to be very careful. Why? And sometimes we have to require DWI images. You can see the when there is a suspicion, difficulty, you can see the growth pattern, hyperintensity area in the DWI or diffusion weighted image. You can see the bladder wall, bladder involvement, and tumor is infiltrating the bladder and going to the bladder. Here it is going to the rectum. So but you have to differentiate between the bullous edema and direct really involvement. This is called bullous edema. There is no involvement. This is a confined to cervix. Sometimes you can see the usually normal vaginal wall, but if you want to see, but here you can see the vaginal wall involvement as well as the pushing the rectum and rectal posteriorly. So if you understand the rectum involvement, post vaginal involvement, you have to put the jelly inside the cervix, mostly vaginal jelly or xylocan jelly. You can see the bladder wall involvement, rectal wall involvement, and the vaginal involvement also you can see nicely. Hydronephrosis you can see in the coronal sections very nicely. Response assessments here, you can see the hyperintense area in T2, but there is no hyperintense area in the response after treatment. But here there is a small residual after externality which is now ready for brachy. You can see this is the hyperintense area and this is now hyperintense, a small hyperintense area, small residual. If you see the nodal distribution starting from the para-aortic nodes, common iliac, left common iliac, bilateral iliacs, external iliac, internal iliac, obturator, anal, horizontal area sets of superficial inguinal nodes, presacral, all nodal distributions are important. If you see perivisceral involvement, inguinal involvement, internal iliac, external iliac, common iliac, para-aortic, you have to see everything. Mostly inguinal and para-aortic node involvement is the non-regional, all are regional. So you have to see from this is the inferior epigastric, this is external iliac, this is obturator and sacral. So mostly the one thing you have to tell, if there is a inguinal node involvement and para-aortic nodes above the renal pelvis involvement, it is called as a distant metastasis. Otherwise, all are regional. Sometimes the nodes in the MRI may looks benign or some suspicious. You have to do PET-CT. Then you can, this will be complement, and PET-CT is superior than the MRI. So when things are suspicious, PETs look suspicious. When things are unclear, think of nuclear. So this is the renal hilar node. You can see this is the aortocaval node between aorta and cavala. Then supramesenteric node. Then para-aortic nodes. Like aortocaval, retrocaval, paracaval, para-aortic, then para-aortic nodes, then inferior mesenteric node, then aortic bifurcation node, then common iliac node, then presacral and common iliac nodes, external iliac and internal iliac and presacral nodes. This is the inguinal node. So if you want to control the inguinal nodes, you remember. So inguinal nodes, this article looks very nice. This is the three muscles. One is called pectineus, rectus femoris and sartorius muscle. The vessels around this is inguinal nodes. So anteriorly, anteromedial, medial, these areas require 1.5 to 2 centimeter, but other sides require 0.5 to 1 centimeter. So this is the margin, cranial, caudal, anterior, posterior, lateral, medial, anteromedially. So anteromedially you have to give 2.5, even laterally to get 2.3 centimeter. So this is the all things about the inguinal node. If you clinically you practice 2D, 2 centimeter below the SCLT versus sorry lesser trochanter you have to take, or saphenofemoral junction or origina profunda femur is the lower level of inguinal node. So take a message for primary CT MRI are complementary to each other. For nodal assessment, PET is superior, lesion looks hypersensitivity, hyperintensity. Breaking up hyporing is a para involvement. Compare with DWI is in diagnosis and response assessment. Welcome to our SON group, Simplified Oncology Network Group, Awareness to Education to Practice. And you can follow my articles and videos, everything, this scanning this code. And thank you very much for watching me.